Okay, hello, welcome everybody. My name is Csirzó Ádám, and I will present you the 3 months progress of my PhD topic, which is endometriosis-related pain relief. Here you can see a quick review about myself. I'm a third-year resident doctor in obstetrics and gynecology clinic of Semmelweis University. We have a mission behind our work, and it sounds like we would like to find the most effective pain relief therapy for endometriosis. And I have also a personal vision, and that is the endometriosis-related pain should be a concept of the past with 1 pill a day. Here you can see my 2 ongoing topics. The first one is a systematic review and network meta-analysis in connection with different medical therapies for endometriosis-related pain. And my second topic fits tightly to my first one because it's a brand new, a very potent new drug for endometriosis. So let me introduce my first topic. Why is it so important, not just for me, for anybody else? Almost every 10th woman suffering from endometriosis. The symptoms can be very diverse, for example, dysmenorrhea, pelvic pain, dyspareunia, and so on. But there are several therapeutic options, for example, medical treatment, surgical interventions, and non-medical strategies. But let's focus on the medical therapies. We should divide it to 2 groups based on the hormonal treatments and non-hormonal treatments. And because of the side effects of the hormonal ones, we should make another 2 groups based on the length of the use of each medication, and that's how we can get short-term and the long-term options. Short-term means we can use it at least 6 months. So as I mentioned, there are long-term therapeutic options, and the bubble, size of the bubble represents you the importance of the drug types. And as you can see, the combined hormonal contraceptives are the first choice in this group. There are short-term therapeutic options, and as you can see, we have 2-1, and the level of the effectiveness is almost the same in the both groups. And what's our question? What is the most effective therapeutic option for endometriosis-related pain? Our population is women of fertile ages with endometriosis. Our intervention and compare is the medical therapies that I mentioned before. And our outcome is the endometriosis-associated pain on different pain scales. We have 2 hypotheses. The first one, oral combined contraceptives are superior to other long-term therapies for endometriosis-related pain. And my second one is GnRH antagonists are superior to other short-term therapies for endometriosis-related pain. And after all, when we find the most effective medical treatment, we can turn this knowledge back to the bedside, and that's how we can increase the effectiveness of pain relief for endometriosis. We performed a systematic search on 3 online databases. Here you can see my numbers, and I highlight you the 4 big box of my search key. Here you can see my flow chart, and at the end of the process, we have 39 eligible paper. And we are doing now the data extraction, and we will finish it until the end of the year. Let's jump to my second project, the relagonist combination therapy versus placebo in patients with endometriosis-associated pain. Another important topic, the endometriosis-associated pain is a distress chronic condition what can lead to impaired quality of life. But in recent years, it's a well-researched new therapeutic option. It's GnRH, gonadotropin-releasing antagonist, which is one of the best short-term option, but there are always a but. Side effects. It's a kind of anti-estrogen, menopausal-like side effects. But how can we avoid this? How can we solve this problem? We can add plus estrogen and progesterone, and that's how we can avoid this unwanted side effects. But you can ask, why this drug? Why now? It's very easy. In 2022, released a new drug in Hungary. our question, is the use of Relagonics combination an effective medical therapy for endometriosis-related pain? Our population, women with endometriosis, our intervention, the Relagonics combination. On the top of the slide, you can see the exact amount of ingredients. Our control is placebo, and our outcome is endometriosis-associated pain on different pain scales. Our aim is to evaluate the efficacy of Relagonics combination compared with those of placebo, women with endometriosis-associated pain. Our hypothesis, the Relagonics combination therapy is superior to placebo, and after all, when we finish this, we can decrease the endometriosis-associated pain. I won't read it loudly, my inclusion and exclusion criteria, but I would like to highlight you. It's always a difficult question how to identify endometriosis, and we will accept both the surgical-based, the histopathology-based, and the symptom-based diagnosis too. And in the exclusion criteria, what is important, we will exclude the patient who have surgical intervention in the previous 3 months. We have 2 arms of our study. The first one is what I mentioned, the Relagonics combination therapy, and the second, the arm B is the placebo therapy, and after 12 weeks, we will make a crossover. And our primary outcome will be the change from the baseline in a visual analog scale. Here you can see a visual analog scale, it's scale 0 to 10. And the secondary outcomes will be the different pain scale, not just a visual analog scale, and different quality of life scales, bone mineral density measuring, and adverse effects reporting. So that was from me for today. And I would like to close my presentation with my motto, quid pro quo, something for something. Thank you.
Dear Ádám, thank you for your presentation. So first of all, it's one of my favorite topics, so just let me ask one question, because you defined pain with a visual analog scale, yeah, from 0 to 10. There is a lot of pain, a lot of type of pain, different pain during the endometriosis. There is the endometriosis is called also the disease of 4 Ds: dysmenorrhea, dyspareunia, dysuria, and dyscrasia. And I mean, well, some of them are cyclic, some of them are non-cyclic.
Yes.
Which one will be released? Which pain will be released? Would you make subgroups, or how could you define it?
The main one is the overall, in the whole month, not non-cyclic, cyclic, the whole pelvic pain. And of course, in the other, there's other subgroups, as I mentioned, or other symptoms, dysmenorrhea, dyspareunia. This will be kind of subgroups. So we will not just these 4, dysuria, dyscrasia, etc., So all kind of symptoms we will examine one by one.
Excellent. Any questions from the audience?
I'm Ádám István. Thank you for this marvelous presentation. I'd like to ask you how many patients do you intend to enroll in your second project?
The second project?
Yes.
Thank you for your question. We made sample size estimation, and of course, based on the previous papers who were dealing with the same, almost the same drug type, it will be enough in each arm 110 to 20. The endometriosis patient is it's a well compliant population, so it will be enough for us. Just 100 and another 100, circa.
Thank you for your presentation. It's a very interesting topic. I was just wondering about the placebo in the second project. If you're going to offer a prior treatment that corrects this pain, or if it's a placebo totally. And also if you're intending to create other protocols so the women do not have to take this medication daily. Or it could be in a bigger interval. I'm not sure. I do not know about this medication, but I was wondering about this as well.
Yes, thank you. Thank you for. Yeah, I'm expected for this one. because we discussed it 100 times, what to choose to do, what to compare with our drug. And the final decision based on, we discussed with experts, see the previous papers, and after all, we would like to reach the pure, the most conspicuous results, and we don't want any disturbing effect, and that's the reason why we choose placebo. I know there's an ethical part, but the crossover is the answer. How would I solve this ethical problem? But yeah, I know it's this is a very critical part of the study, but I think with the crossover we can solve this.
Thank you. Congratulations for your presentation. I'm going to have just a question. After a crossover in your second topic, how can you know that after the Resiligo in arm A, you cross over to placebo and you don't have a long-term effect of Resiligo that will eliminate the pain?
Thank you for the question. I didn't mention, but we would like to make a 1 month washout period, and that's how we would like. I didn't highlight in my presentation, so thank you for your question.